The Deputy Vice Chancellor, Development Services, Professor Ayodele Ashenua. The Deputy Vice Chancellor, Management Services, Professor Lucien Chukwu. The Deputy Vice Chancellor, Academics and Research, Professor Bola Obo. The Acting Registrar and Secretary to Council, Mrs. Olakunle Imakinde. The Bursar, Mrs. Oluwafunmilola Adekunle. The University Librarian, Professor Yetunde Zaid, ably represented by Mrs. Adetoun Adekonye. The Provost College of Medicine, Professor David Oke. The Dean, Faculty of Clinical Sciences, Professor Folashade Akinshola. Distinguished ladies and gentlemen, gentlemen of the press. I welcome you all to the 20th inaugural lecture of the university in the 2023-2024 academic session, titled, It's Your Heart, Guard It with All Diligence, Every Heartbeat Counts. Our inaugural lecturer is Professor AMAM CHINYERE MBAKWEM, the current head of Department of Medicine, Faculty of Clinical Sciences. Professor MBAKWEM was born on 6th March 1957 to the family of late Mr. George Nwawiku and Mrs. Justina Afokwalam. She graduated with a Bachelor of Medicine degree from the College of Medicine, University of Nigeria, Nsukka in 1981, and thereafter completed her housemanship at the University of Nigeria Teaching Hospital in 1982. Her postgraduate training was undertaken at the Lagos University Teaching Hospital under the West African College of Physicians and the National Postgraduate Medical College. She passed the membership exams of both colleges and obtained the fellowship of the West African College of Physicians in 1997 by examination. Professor MBAKWEM undertook training in cardiology at the Wolfson Heart Institute, Tel Aviv, Israel, in 1999. She also obtained a fellowship in medical education from the Foundation for Advanced International Medical Education and Research, FAMA, Institute in Philadelphia, USA, in 2007. Her research interests include heart failure, systemic and pulmonary hypertension, heart disease in women, effective communication in disease management, and the psychosocial issues in cardiovascular disease. Professor MBAKWEM joined the service of the University of Lagos as Lecturer 1 in 1999 and was appointed professor in 2015. She is the Director of the Medical Education Development Unit, College of Medicine, where she has successfully executed the Pfizer Global and Novartis heart failure grants, as well as participated in large international and national landmark trials that have acronyms like Invictus, PAPUCO, Approach, Euro Observational PPCM Study, Inter-Aspire, RACE, Peace, and SPEC AI. Our inaugural lecturer has been a resource person at update courses of the West African College of Physicians and the National Postgraduate Medical College. She has served as an examiner for the West African College of Physicians for the last 11 years and external examiner to the University of Benin, University of Nigeria, Nsukka, Obafemi Awolowo University, Ile-Ife, and Lagos State University. She has also assessed candidates for professorial chairs for the University of Nigeria, Nsukka, Ilorin, Alex Ekweme Federal University, Ndufu Alike Ikwo, Ebonyi State, and Lagos State University, and the University of Port Harcourt. Professor MBAKWEM is a member of many local and international professional bodies, including the Nigerian Cardiac Society, the Nigerian Hypertension Society, Pan-African Society of Cardiology, PASCA, the African Heart Rhythm Association, the European Society of Cardiology, the American College of Cardiology, and the European Heart Failure Association, as well as the Atrial Fibrillation Screening Association. A past president of the Nigerian Society of Cardiology, she is the current vice president, West Africa region of PASCA, as well as board member and vice president-elect of the World Heart Federation. With over 96 publications in peer-reviewed journals, Professor MBAKWEM is a member of the Annals of Clinical Cardiology Editorial Board. She has also contributed to book chapters and presented over 100 abstracts at national and international scientific meetings and conferences. Distinguished ladies and gentlemen, it is my honor to invite Professor AMAM Chinyere MBAKWEM to present her inaugural lecture.
Vice Chancellor Academics and Research, the Deputy Vice Chancellor Development Services, the Deputy Vice Chancellor Management Services, the Registrar, the Bursar, the University Librarian, the Provost College of Medicine, the Dean Faculty of Clinical Sciences, other Deans of Faculty present, other Principal Officers of the University, members of the University Senate, heads of departments, distinguished academics and professional colleagues, distinguished non-teaching and staff, your lordship, spiritual and temporal, dear students, members of the press, distinguished guests, ladies and gentlemen. I'm eternally grateful to God who has made this day possible. Thank you, Madam Vice Chancellor, your management team, and the University Council for giving me the opportunity to deliver this lecture. I thank my family for their support and encouragement and being my most dedicated cheerleaders. I thank my late parents for their belief in me even when I thought I did not have it in me to become what I am today. I am really a manifestation of the words in the book of Proverbs 19:21, which says, "Many are the plans in a man's heart, but only the counsel of the Lord will stand." I thank God who has ordered my steps aright on this journey. I say this with all humility and gratitude because of two events that happened in my career journey. Madam VC, I wanted to drop out of med school in my first year. I have a big sister who is a doctor, so she graduated as I was entering university, and we thought we would see her at home. And there she goes off to Ibadan to do primaries, and then goes to Ghana to do ECFMG. And I said to myself, is my life as a doctor going to be endless examinations? So I called a family meeting and told my father I wanted out. So they tried to convince me, and when they couldn't, they took me to a family friend, a professor of pediatrics, late Prof. Zubike. That didn't work. They used a funny psychology on me. They said to me, okay, why don't you work hard? You know, medicine is competitive. If the registrar hears this, they'll give up your space. Why don't you work hard, get a good GPA, and then we can change course in second year. In working hard, I got the best result in my first year. I made the dean's list. I got a university scholarship. The rest is history. The second thing that happened was choosing a career, choosing a specialty when I entered residency. Apologies, Prof. Olumide. I had entered residency with a mindset to do dermatology because I had lofty business ideas. I wasn't going to be running around the world. I was going to set up a clinic and a cosmetic shop, a big cosmetic shop next to the clinic. Thank God for beautiful skin. So if you ask me my routine, I'll direct you to the shop. But, Madam Vice Chancellor, it was a frustrating time. A patient comes in and all I see is a rash. Professor Olumide, doing of dermatology, passionate about everything on the skin, says, this is a papulosquamous lesion. Can't you see the silvery scales? Arrange the mosaic pattern. Madam Vice Chancellor, I will look, and all I see is a rash. But to avoid being told off, I say, yes, Prof, I see it. After a few clinics, I had an honest conversation with myself, and that is why I'm giving this inaugural lecture in cardiology. So let's look at the heart, the function of the heart. The human heart is a very wonderful and special organ. It starts beating up between the 22nd to the 28th day of intrauterine life, and it beats about 60 to 100 times per minute, and about 52 million times a year. So ladies and gentlemen, if you multiply your age with that number, it gives you an idea of how hard this small fist-sized organ in your chest, how hard it works. The rate can vary because of the autonomic system. The sympathetic increases the rate, and the parasympathetic reduces the rate. With each heartbeat, the heart squeezes about 70 mils of blood and about 5 liters in a minute. This ensures that the metabolizing tissues get their requirement, the oxygen and the nutrients they need. It doesn't take a rest, never goes on vacation, doesn't even take a bathroom break. Complains when it is tired and can no longer function effectively, and will resultant symptoms. How does this heart develop? Looking at the embryology, it's the first functional organ to develop in the embryo, so you know why I settled there. So from an embryonic tissue called the mesoderm, and with a lot of signals going on, it forms two cords. The lumens develop in the cord, and the cords fuse, and they twist, and they turn before we have the heart being developed. The precision and timing of these stages are of utmost importance, Madam Vice Chancellor. Any errors will result in congenital heart diseases, some of which are not compatible with life. So, Madam Vice Chancellor, this is what I've been trying to describe. This is the embryo with the cardiogenic area. These are the two cords, then they form lumen, then they fuse. You can see the turns and the twists, and anything can happen. And this is where we want to get to, where you have two atria on the left and on the right, and two ventricles on the left and on the right. The above process can be summarized in these steps. I don't want to bore you with all the details. Looking into a bit more detail about the structure. The heart has 4 chambers, 2 atria on the left and the right, and 2 ventricles on the right and on the left. The chambers are separated by atrioventricular valves, which serves as gates, and the ventricles push out blood through 2 major arteries, aorta from the left ventricle, pulmonary artery from the right ventricle. And the structure is also divided into 3 major parts. The muscular part that does all the work and all the pumping. Then we have the vascular system that brings in the blood for the working muscles and also drains the metabolites that happen with all the issues. And then we have the electrical system This is called the conduction system, which acts as electrical circuits. It kickstarts events and makes sure there are no short circuits, because when that happens, there will be issues. Madam Vice Chancellor, many parts of the heart can become dysfunctional simultaneously. But usually what happens, one part becomes dysfunctional and recruits other parts. After all, there's love in sharing. Diseases of the heart can be put into two major baskets: the congenital and familial, and the acquired heart diseases. The title of this inaugural lecture, It's Your Heart, Guard It With All Diligence, Every Heartbeat Counts, reflects both my passion and the stark reality I face daily in my line of work. Proverbs 4:23 says, keep your heart with all diligence, for out of it spring the issues of life. Madam Vice Chancellor, this is true both spiritually and physically. Your thoughts, emotions, belief system will affect who you become, your personality traits, and your character traits. Also what you eat, what you drink, what you smoke, what you inhale, your lifestyle will affect your heart, either positively or negatively. It can affect the muscles leading to pump failure. It can affect the arteries and they get clogged up and blood supply is cut off. It can also affect the electrical system, and we talk about arrhythmias. Anyone who has taken part in the resuscitation of a cardiac arrest patient understands the joy, relief, and sense of accomplishment when the first heartbeat returns. I would like to focus this discussion majorly on heart failure, which is the common rites of passage for most cardiovascular diseases if the patient lives long enough. Madam Vice Chancellor, the cartoon I have there is called the cardiovascular continuum. These are the risk factors. We don't want you to enter the circuit, because once you get into that circuit, your final common exit pathway is via heart failure or kidney failure, and then finally death. So heart failure, why, how, where are we presently, and what are my contributions? I have a lot of challenges, Madam Vice Chancellor, convincing my patients that they have heart failure. The next question they ask me, if my heart has failed, how come I'm still walking around? And they don't believe me. But when we say the heart has failed, it means the heart has difficulty ejecting or receiving blood due to structural or functional abnormalities in the heart. Heart failure has been described as the pandemic of the century. The burden of heart failure continues to rise because we are getting older, and of course there are a lot of risk factors around, like hypertensive heart disease, cardiomyopathies, and a lot of the congenital heart diseases. Because of improvement in technology, we are helping them to survive into adulthood, and heart failure is their final common exit pathway. We categorize heart failure into three major parts using the ejection fraction. We talk about heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. This is where we have the wealth of evidence in the management of this disease. Then we have heart failure with mildly reduced ejection fraction, and then we had heart failure with preserved ejection fraction. So the ejection fraction looks normal, but the heart is still failing. We also classify the functionality of the patient using the New York Heart Association functional class. NYHA 1 means that you don't get breathless except you exert yourself, severely. NYHA 2, moderate exertion gets you breathless. NYHA 3, little activities of daily living gets you breathless. In NYHA 4, the patients are breathless even sitting down at rest. Heart failure epidemiology, where are we? Like I said earlier on, the burden of heart failure continues to grow globally, Nigeria inclusive. It's said that about 64 million people are living with heart failure worldwide. The prevalence is about 1 to 2% in the general population, and up to 10% for those who are 70 and above. And the rising burden we have talked about earlier. Madam Vice Chancellor, the increasing burden in our environment we elegantly demonstrated in a recent review that was published. My team and I, demonstrated the continuous rise in the number of acutely decompensated heart failure patients being hospitalized at the Lagos University Teaching Hospital over a 60-year period. Heart failure admission made up 38% of all cardiovascular admissions and 7.5% of medical admissions. We demonstrated a rising trend during this period under review with a cumulative quadrennial increase of 1,590%. This is a paper. If you pay attention to the gray bars, you can see the rising burden of heart failure admissions, the first 4 years, second 4 years, third 4 years, and then the last quarter of the study. And this was also followed by the rise in trend on cardiovascular disease admissions and deaths, whether you're looking at them in actual numbers or you're looking at them in percentages. So the profile of heart failure, Madam Vice Chancellor, is different in sub-Saharan Africa and most low and middle income countries. Heart failure occurs in the middle age in our environment as opposed to the elderly in the West. Other studies and that of our colleagues that we have done have shown that heart failure happens about a decade or two earlier in our environment compared to what is happening in the West. These are studies with different mean ages. Lowest is 49 and highest is 56. And the commonest risk factor in our environment includes hypertensive heart disease, dilated cardiomyopathy, valvular heart disease. Ischemic etiology is commoner in the West than with us here. Our patients present very late to the hospital for many reasons. Ignorance leading to delay in seeking medical care, poverty, difficulty with accessing healthcare facilities, and late and missed diagnosis. So that takes me to heart failure diagnosis. Traditionally, it's a clinical diagnosis. But recently, the major cardiovascular societies have added evidence of structural abnormality and functional abnormality to demonstrate heart failure. For good reasons, because sometimes diagnosis of heart failure clinically is daunting, especially in the emergency room where everybody comes in, most people come in breathless, or in women or patients who have heart failure with preserved ejection fraction. And studies have shown that there is a poor correlation between the right diagnosis and the diagnosis the physicians are making in the emergency room. So biomarkers like natriuretic peptides in heart failure diagnosis have been suggested by the European Society of Cardiology and the American College of Cardiology to overcome these obstacles. Levels of natriuretic peptide for diagnosis are displayed on the screen. So levels are whether you're dealing with ambulatory care or dealing who are acutely compensated. So they study the Lagos Teaching Hospital by Lagos University investigate the reliability and accuracy of points of care minor natriuretic peptide in heart failure diagnosis. The anti-ProBNP cutoff use was 961 picograms, and ProBNP demonstrated a negative correlation level for none. And the thing, Madam Vice Chancellor, is that cutoff reference of 72 picograms per ml would have better sensitivity, specificity, negative predictive value, positive predictive value when compared with the manufacturer's recommended value of 125 picograms per ml. So we concluded that there needs to be a local study to validate this new cutoff point that our group has come up with. What of outcomes in heart failure? It has remained poor, with little improvement despite the discovery of new medicines and technologies. Madam Vice Chancellor, in 5 years, 50% of our acutely decompensated patients will be dead. In 3 years, 34% of them who are in the better classes, NYHA classes, will be dead. 42% of those in the higher classes will be dead. Heart failure kills more people than cancer. And I show you this. This is a study comparing the 5-year mortality of heart failure and common cancer. This is breast cancer, this is Hodgkin's lymphoma. But once we hear cancer, everybody's antenna is up, but heart failure is killing more people than cancers. So how are we doing in our environment? Outcome is actually worse in our environment because of a plethora of reasons. There's ignorance leading to late presentation, poverty and high cost of healthcare, huge burden of uncontrolled risk factors. The inter-CHF study that we participated in looked at global disparities in the profile of heart failure patients. The one-year mortality was highest in Africa at 60%. So this, if you focus on this highlighted bar, this is for ambulatory care patients and this is for acutely decompensated patients. Compare with India, Southeast Asia, Middle East region, South America, China, overall, Africa is not doing well at all. In-hospital mortality from heart failure has also been rising over the years, as was seen in our study. We showed a rising mortality from 8% in 2005 to 14% in 2017. And we had earlier demonstrated that heart failure contributed about 40% of hypertension-related deaths in the emergency room in an earlier study. So these, the blue bars, are the mortality. The rise is not as high as the admission rates, but that doesn't mean we're doing very well. Patients with heart failure are also prone to frequent rehospitalization, especially in the first 3 months after discharge. Studies have shown that up to 25% will be back in hospital within a month. Outcomes are worse for those who are in the higher NYHA classes. In a recent study on short and long-term outcome in about 300 hospitalized patients that were carried out at the Lagos University Teaching Hospital, mortality was 19%. Rehospitalization was 12.4%. Oh, Madam Vice Chancellor, the most annoying thing is that this would happen within 3 months of discharge from hospital. So this is a crucial period that all of us must look out for, because that's when the patients fall through the crack. So this is our study, from our study. If you look at the mortality was 19.4%. 89% of that happened in less than a month of leaving hospital. And within 3 months, we had all those who wanted to die had died. So the ones who survived went on to other things. What of comorbidities? We see them frequently in patients with heart failure. And once they are present, they actually affect outcomes adversely. Things like diabetes mellitus, thyroid disease disorders, obesity, iron deficiency, frailty, and pulmonary disorders. A study from our center demonstrated that about 39% of our patients who we admit acutely have pulmonary hypertension. It's commoner in males. It's a man's world, isn't it? And in those with worse NYHA classes. And we found that also the ones with worse ventricular functions also had, pulmonary hypertension. And we followed these patients up for about a year. And this is a Kaplan-Meier curve, showing that if you have pulmonary hypertension, your possibility of surviving over the year is worse than if you didn't have pulmonary hypertension. Heart failure is a multi-organ event. There is multi-organ involvement and psychosocial disturbances. So because of these recent findings and outcomes in heart failure, most of the international societies have redefined heart failure. Forget the simplistic definition I gave you before as heart failure. So the European Society of Cardiology defines heart failure as a clinical syndrome characterized by typical symptoms like breathlessness, ankle swelling, fatigue, may be accompanied by signs, elevated jugular venous pressure, pulmonary crackles, and peripheral edema, cultural or functional cardiac abnormality resulting in reduced cardiac output. So there's a lot more going on than the heart. I was at a meeting once, and there was a poster that said heart failure is dragging down everybody. So there was the heart, sinking to the bottom of the pool, dragging the kidney, dragging the liver, dragging the lungs, everybody with it to the bottom of the tank. Psychosocial issues in heart failure. Patients with heart failure are generally depressed. It's said that about 13 to 77% of those who have acutely decompensated will be depressed. And 13 to 42 of those who are in ambulatory care will be depressed. In a study we carried out in Louth with our psychiatric colleagues, 2/3 of our patients who were acutely decompensated were depressed. And 1/3 in ambulatory care were depressed. About 19% of those had moderate to severe depression that needed psychiatric workup. And they were referred to Yaba, but they didn't go because of the stigma. Once I say Yaba left, you know what it means in Lagos. So this led to our unit starting a liaison clinic with the psychiatrist as a one-stop shop for the patient, a first of its kind in Nigeria. Madam Vice Chancellor, we also demonstrated that our heart failure patients had psychological pain in almost 50% of them. And about 27% of them had low self-esteem. We opined from that study that our patients may be committing suicide inadvertently because the depressed patient who has psychological pain, who has low self-esteem, is less likely to take his medications or adhere to recommended lifestyle modifications or disease management. Patients with heart failure also have poor quality of life. In the study we carried out in Louth, about 25% of our patients had very poor quality of life. Madam Vice Chancellor, we feel that this psychosocial aspect is worse for us in Africa, in Nigeria. I showed you the mean ages of our patients, 52, 56. People are getting to the peak of their careers. They still have social responsibilities, and this is the time they're taking out of action, as opposed to heart failure that would happen in retired elderly people in the West. What is the economic burden of heart failure? Heart failure is an expensive disease to treat. In 2012, it was said that the global cost of treating heart failure was put at $102 billion. About 65 was direct cost, 45 was indirect cost, and 70% of that was spent on hospitalization. And it is projected that by 2030, the cost will go up by about 127%. Payment for heart failure management in our environment constitutes catastrophic health expenditure as defined by WHO. WHO says health expenditure is catastrophic if it is more than 40% of the non-subsistent income of the family, or out-of-pocket payment for heart failure that is about 10% of the household income. Madam Vice Chancellor, we showed in a study we carried out in Louth, looking at the cost of hospitalization for heart failure. The cost we came up with was $430, which looks small compared to $2,500 or $3,000 if you're looking at studies from the West. However, we concluded that the economic burden was higher in our environment because 60% of our patients were low-income wage earners or artisans. And if you put this $430 against the $120 that was the minimum wage at that particular time, what it means is that for every admission, a heart failure patient spends 4 times his salary. That is catastrophic health expenditure. And now, peripartum cardiomyopathy. Madam Vice Chancellor, this is heart failure that is even more heart-rending. This is heart failure that occurs in the last month of pregnancy or up to 5 months post-delivery. And these are women who went into pregnancy normal, no cardiovascular problems at all. The prevalence varies from 1 in 100 births in Nigeria to 1 in 20,000 births that we participated in. The prevalence rate from 1 in 100 live births in Zaria and 1 in 1,350 live births in Lagos. So this map just shows you the changing face of epidemiology of PPCM. This was Prof. Parry's map of Nigeria, PPCM of Nigeria. If you look at the north central areas, had all these maps from Peace Registry, and all over Nigeria, PPCM occurs. There are many theories about the etiology of PPCM. The most plausible is the 16 kilodalton fragment from the breakdown of the nursing hormone called prolactin. And this 16 kilodalton fragment damages the arteries and also the heart. Other theories like selenium deficiency and hypertension in pregnancy have also been implicated. So as the woman is nearing term, there's increased production of prolactin to help the woman lactate, produce milk for the baby. But cathepsin D can break down that prolactin and produce the 16 kilodalton fragment, and this damages the vessels and also damages the muscles of the heart and causes dilatation and dysfunction. Harmful birth practices of postpartum women in northern Nigeria was initially implicated. These women lay on heated mud beds, they consume potash, kawa, in their broth, and they bathe in extremely hot water. Madam Vice Chancellor, if you look closely at this picture, this is a nursing mother with a baby sitting on a mud bed, and there is fire under the bed. And this is the amount of potash they will put in the broth for the woman. No wonder their hearts failed. This was not demonstrated in the recent nationwide peace registry that I had talked about earlier on. There was no association between PPCM and harmful birth practices, as we demonstrated in that study. The only relationship with PPCM was with poverty and lack of antenatal care, and that means we can do something to save these women. We also participated in the largest global PPCM registry with about 750 women, and this demonstrated that PPCM is a global disease. Doesn't matter where you're coming from. Yes, there are differences in ethnicity, but everybody can get the problem. This is a map. You can see whether you're coming from North America, South America, you're coming from Europe, Africa, Australia. There were PPCM being contributed. The baseline characteristics look the same, but there were some differences. People in low and middle income countries and African Americans were likely to present late, had more severe disease, and poorer outcomes. And when you broke it down to the African women, they were younger, they had a higher frequency of HIV infection, had the highest size of their left ventricles, they were more likely to have a delay in diagnosis from symptom onset. The common drugs we use for heart failure were used for them, but the other pillars of management were not used for these patients. How do they do? What is the outcome? It's variable. Though it's said to be better than idiopathic cardiomyopathy, the thing is that some women will recover, some will die. Others will not recover. The poor prognostic signs include, very large hearts, poor functioning hearts, and, being African American, or coming from here. And the other complications that can happen, things like embolism, arrhythmias, and sudden death. And also the babies also die. There's increased fetal wastage. And recurrences can happen. Madam Vice Chancellor, we cannot say the woman who would have another episode of PPCM, even if they recovered function after the first one. So we looked at the outcomes, the 6-month outcomes with our groups at the EORP registry. And this is what we found. Only 46% of them recovered. 10 were readmitted within the 6 months. 6% had died. 7% had an embolic phenomenon. 5% of the babies had also died. Madam Vice Chancellor, diagnosis of PPCM is usually delayed, and this leads to late referrals to the cardiologist and also leads to poor outcomes. So there's basically, because there's overlap of symptoms of PPCM to the postpartum period, things like, and the woman who just had a baby starts complaining, and we wish it away and say it's postpartum blues, she has fatigue from anemia, from blood loss during delivery, or it's postpartum fluid retention. So our PPCM working group of the Heart Failure Association has written and updated several position papers on the diagnosis, management, and follow-up of women with PPCM for non-cardiologists and obstetricians, so that these patients can present early and be looked after properly. So this was the first one, and this is the second one, giving guidance to non-cardiologists for early recognition and early referral of these patients. Madam Vice Chancellor, I've been painting a very gory picture. So is there something we can do about it? So we thought we tried, what can we do to improve heart failure care in our environment? And we looked at two aspects, education and heart failure clinics. So to mitigate the poor outcomes in our heart failure patients, my group and I, the Heart Failure Collaborative Group, set out to improve the general practitioner's knowledge and skills in the management of heart failure. With the grant we got from Pfizer Global and Novartis, we did a situation analysis, we did curriculum development, and we had different training workshops. We had done about 3 workshops in Lagos, 1 in Enugu, 1 in Abuja, and we're planning to roll out to all the other geopolitical zones. And Madam Vice Chancellor, the outcome has been quite impressive. So this is the pre and post-test scores of these primary care physicians. You can see there's improvement in the knowledge and the skills, which was significant, but whether this translates to actual care is another level of discussion. Thank you. And the physicians were also very glad to have attended the workshop because we evaluated the workshop using the Kirkpatrick model, and the expectations were met. The impact on current practice was quite good, and they were willing to share learnings from the training with their colleagues. Setting up a heart failure clinic. We know that rehospitalization and death are quite common in the first month after hospitalization. We had observed that our patient, in our earlier studies, that our 1-year mortality was quite high. And most of the mortalities occurred outside the teaching hospital, where there is questionable expertise in looking after these patients. But we know that it could be very daunting to navigate healthcare in a big tertiary hospital. So we set up a dedicated heart failure clinic, one of the first in the country, and the aim was to ensure adherence to therapy, health education, medication optimization, and also to help these patients navigate care that they need apart from heart failure care within the hospital. And presently, we are working with a technology group. We're trying to develop a self-care app that will help us with patient education, medication and clinic reminders, and also monitoring of patients for red flags, and determine whether the patients need to come in or not. A pilot of that study will be done to test acceptance, ease of use, and patient adherence, and we hope to roll out within the next 3 months. Madam Vice Chancellor, effective communication improves outcomes in chronic diseases like hypertension. Of course, we know hypertension is elevated systolic and or diastolic blood pressure above what is accepted for the patient's age or sex. For an adult, 140 is our cutoff point. The story in Nigeria is abysmal. 39% prevalence. Only 29% are aware that they have hypertension, and only 12% of them are controlled. And we know hypertension is a major CV risk factor. It's the one driving stroke, it's the one driving heart failure, it's the one driving kidney failure in Nigeria. And the relationship is a straight line curve. For every 20 millimeter systolic and 10 millimeter diastolic increase, you double your 10-year cardiovascular mortality. So we need to control the blood pressure. But why are we not doing well? And we had looked at contribution of hypertension to the acute emergency death in our hospital. And stroke was 52%, heart failure 40%, acute myocardial infarction 4%, uremia 2.4%. But Vice Chancellor, complications arise because of poor control, and poor control happens at different levels. At the patient level, at the policy level, at the healthcare provider level. Most of us healthcare providers lack the skills to properly counsel and educate patients. And we know that good communication skills by healthcare providers increases patient adherence to medication and healthcare plans. Madam Vice Chancellor, poor adherence to subsequent catastrophic outcomes was what set me off to pursue a fellowship in medical education with focus on doctors' communication skill. I am the expert. I have the skills. My patients show up. 1 year, 2 years, they drop off the clinic. And the next time I see them is in the emergency room. Either their hearts have failed, or their kidneys are packed up, or they've had a stroke. So my team and I conducted a needs assessment survey to determine the willingness of medical students to be taught communication and counseling skills in medicine. This is very interesting. The medical students, over 90% of them, felt their communication and counseling skills were either excellent or above average. But when we now asked them, would you want a formal training in communication skills? This was their answer. Most of them wanted a formal training. So discordance. So what did we do, Madam Vice Chancellor? We trained faculty members to act as preceptors for students' training. We developed training materials and procured videos for role-play scenarios. We had 2 batches of 600 medical students. The first batch we used as control. We examined them as they entered into medicine and at the end of it without any intervention. The second group, we examined at the beginning. They had lectures on communication and counseling skills, reviewed videos on different counseling scenarios, and took part in role plays where they played, the counselor, counselee, and feedback reporter. Madam Vice Chancellor, here are our results. On all the stations, after the training, the medical students did much better. And when we did the total OSCE scores, they were actually much better. And we had used different scenarios to examine this candidate. We used the standardized patients, we used clinic patients, and we trained the patients themselves to rate the students' counseling skills. It's interesting that the patients actually rated the students better than the lecturers, significantly. Whether we're looking at mean scores or we're looking at global rating. And then whether we're using standardized patients or clinic patients, it didn't matter. The faculty, did the same. So these are some of the pictures, some of the students during the role play sessions, and the highlighted people are faculty members sitting in as preceptors during those sessions. Madam Vice Chancellor, the findings from this project was presented as part of the fellowship requirements at the Global Education Forum of the Foundation for Advancement of International Medical Education and Research, FAMA, Philadelphia, USA. This is yours truly presenting the paper. And these are some of my classmates with faculty members, the 2007 FAMA group. So, Madam Vice Chancellor, what have I contributed to the society at large? On the professional scene, Madam Vice Chancellor, I would like to appreciate the University of Lagos for giving me the pedestal to contribute to the cardiology profession on the national, regional, and international scale. I am the only, so far, female president of the Nigerian Cardiac Society. And if you know cardiology, it's a male arena. And I completed my tenure successfully. I also sit as vice president of PASCA and vice president-elect of the World Heart Federation. Madam Vice Chancellor, I'd like to appreciate the Almighty God for his grace and mercies and loving kindness. The Vice Chancellor who was first my provost before we donated her to the university at large to become the VC. To all the VCs I've worked under, to my present provost, it's been a long journey. I also like to appreciate all the provosts that I met in my career. The present CMD, Prof. Sowasu, thank you for the good work you're doing in Luz. My present dean, the action woman, if you know her, you know her. Thank you for your support and doggedness. To all my past head of department, Prof. Solumide, thank you for all the work you did with us. Members of the Department of Medicine, we call ourselves the striding department because we are striders and we are setting the pace. I would like to mention Professor Ginny and Mira Fasomade Okubadejo. We all started this journey a few years ago as junior residents. And here you are, you have become specialists, you become gurus in your own subspecialties. Well done. And to all the young cardiologists who have become faculty members, Dr. Amadi, thank you for all the support. Dr. Olusegun Joseph and Dr. Kushimo, I know I must have stretched you a bit, but it's all for the good of the patient. To my numerous mentees, thank you. You give me hassles, and I also give you hassles. But at the end of it all, we come out shining. The planning committee, Dr. Amadi, Dr. Bieli, leading the pack, thank you so much for the work done. Madam Vice Chancellor, I would like to appreciate the staff of MEDU because they were quite helpful in the birthing of the Spices curriculum. We graduated our first set of the Spices curriculum this year in March. To my numerous collaborators, locally, Professor Kia, Julichukwu, the rest from around Nigeria and on the international scene, thank you for working with me. A big thank you to my patients who consented to participate in my research despite the inconveniences. Your contribution to this journey and the improvement in knowledge that is reshaping patient care is unquantifiable. To my students, some of whom have become lecturers, associates, senior lecturers and associate professors, well done. To the men and women of God who stood there for me, spiritual support, Pastor Adiola Mensah, Reverend Titi Mensah, Pastor Shola Balogu, Pastor Rotimi, Pastor Deji, thank you so much for all the support. My special friends, Pastor Ese and Rekia, thank you for all the support and all the trouble you give me in church. And to my Sunday school group and workers in the educational directorates, thank you for making the work of ministry easy. To my family, you are the best I could ever be, I could ever hope for. To my late parents, thank you for setting me up on this path. Papa, I'm sure you are watching from heaven, but would have been the proudest parent if you were alive. You were always my greatest cheerleader, despite the hassles I gave you as a very stubborn child. In my early days, yes, I gave the man hassles. Your guidance and the grace of God is what has made this day possible. To my siblings, Phyllis, Akogo, Ihoma, Ibarian, the fights, the wranglings, the makeup afterwards, the support, the counsel, whether sought for or unsought for, that you offer. Thank you. A big thank you to all my cousins, my nieces, my nephews, all my in-laws. Thank you for being there for me and for all the support you give. God bless you all, and thank you for coming.
Please be seated. Let me recognize a mentor of Professor MBAKWEM, an emeritus professor, one of the great women in medicine, Professor Yetunde Olumide. Thank you very much, ma'am. I also recognize distinguished Professor Babajide Alo, a former Deputy Vice Chancellor, Academics and Research. The gold medalist, Professor Duroni, also a former Deputy Vice Chancellor, Management Services. Olurotimi Shodimu, Esquire, former Registrar. Professor Afolabi Leshi, former Provost, College of Medicine. Professor Lanre Adeyemo, the CMD, Lagos University Teaching Hospital. Thank you for coming. I also want to thank the Reverend T.T. Mensah, Pastor Adeola Mensah, and the entire members of the Redeemed Christian Church of God, Jesus Sanctuary. Thank you. Pastor Peter Adobamen, a pastor and friend of the lecturer. I also recognize family, Franklin Uzo Oji, Juliet MBAKWEM, Chioma Ogu, Ngozi Akintujoye, and Mrs. Gaga Ojo, family and friends. Thank you very much. Last but not the least, I recognize Phyllis, Akwaogo, Ihuoma, Ibari, the siblings who often gave unsolicited advice. Thank you very much. The Deputy Vice Chancellor, Development Services, Professor Ayodele Ashenua. The Deputy Vice Chancellor, Management Services, Professor Lucien Chukwu. The Deputy Vice Chancellor, Academics and Research, Professor Bola Obo. The Acting Registrar and Secretary to Council, Mrs. Olakunle Makinde. The Bursar, Mrs. Oluwafumilola Adekunle. The University Librarian, Professor Yetunde Zaid, ably represented by Mrs. Adetun Adekonye. The Provost College of Medicine, Professor David Oke. The Dean, Faculty of Clinical Sciences, Professor Folashade Akinshola. Distinguished ladies and gentlemen of the press. We have just listened to the 20th inaugural lecture of the university in the 2023-2024 academic session titled, "It's Your Heart, Guard It with All Diligence, Every Heartbeat Counts." It was delivered by Professor AMAM Chinyere MBAKWEM, the current head of our Department of Medicine, Faculty of Clinical Sciences. The lecture captured the academic and research activities over the last 2 decades in areas such as heart failure, heart disease in women, and psychosocial issues in cardiovascular disease. Using her personal experience as well as graphical statistics to highlight her findings as regards the impact of heart disease, our inaugural lecturer provided a clear structure on key aspects of heart health, disease prevention, and management. She showed that heart failure caused more deaths than individual cancers. And she also highlighted the fact that patients with heart failure often died within 3 months of discharge. Of note are her years of work with other collaborators on peripartum cardiomyopathy. This particular research showed, amongst others, that it exists in southern Nigeria, unlike what was previously believed. They were able to show that it was not just a disease of the north. It also came out very clearly that it was a disease of poverty and poor antenatal care, which meant that it was very preventable. These findings led to publications of position and guidance papers on diagnosis, management, and counseling on subsequent pregnancies in women with postpartum cardiac myopathies. Professor MBAKWEM demonstrated with evidence-based and targeted training, The skills of primary care physicians could be improved for early diagnosis, treatment, and referral of heart failure patients, thereby improving outcomes. She also showed that communication skills of healthcare personnel can be improved by training, leading to effective patient counseling and improvement in self-care of patients with chronic diseases. She demonstrated that 2/3 of patients with heart failure are depressed and therefore need care. All these have led to the formal introduction of communication skills training in the medicine curriculum of the University of Lagos. Professor AMAM CHINYERE MBAKWEM, now that you have successfully paid your academic debt to the University of Lagos with today's brilliant inaugural lecture, on behalf of the Senate, you are hereby discharged and acquitted. I therefore welcome you to the committee of professors that have paid their dues. Congratulations. I thank you all for coming and wish you safe return to your various destinations. I hereby declare this assembly closed.